please allow me to now introduce our speaker for today's session, Melissa Gibbons, Assistant Professor, Certified Genetics Counselor with Pediatrics, Clinical Genetics, and Metabolism with Children's Hospital, Colorado. Thank you all again for joining us today. Now let's begin.
Hello, thank you for having me to speak about spinal muscular atrophy in light of newborn screening. Just some quick disclosures. I do serve on the Medical Advisory Committee for Cure SMA, and I have served as a speaker at an Avexis-sponsored dinner. Today, we are going to discuss the natural history of spinal muscular atrophy and how that natural history is changing. We're going to highlight currently available FDA-approved treatments, and we're going to review different methods, including newborn screening for shortening the road to diagnosis and treatment. Spinal muscular atrophy, or SMA, is actually a clinically and genetically heterogeneous group of diseases in which there is a loss of anterior horn cells and progressive muscle atrophy and weakness. During this conversation, we are going to focus on one type of spinal muscular atrophy referred to as 5Q-related SMA. This is the most common form of spinal muscular atrophy, and it is believed to account for about 95% of all cases. The incidence is currently thought to be 1 in 10,000 live births. It is an autosomal recessive disease, indicating that in most cases, parents are a carrier and have passed on the genetic change at the same time to their child. It has a 1 in 54 carrier frequency across all ethnicities, with some ethnicities being higher, and we'll address that a little later in the presentation. It is seen across all ethnicities, and it is caused by either a homozygous deletion or a deletion in a pathogenic variant in the survival motor neuron 1 gene, making it a monogenetic disorder. When we think about the genetics of SMA, a vast majority of the changes are due to a deletion or a gene conversion in the SMN1 gene. In fact, deletions and gene conversions account for 95% of all cases. 5% of cases have a gene deletion on one allele and a point mutation on the second allele. This accounts for the remaining 5% of genetic conditions. This is important to note because common SMN1 testing tends to focus on deletion only, and therefore some individuals could be missed if the reporting laboratory does not report out carrier status. If there is an individual in which SMA is suspected and their test results show a carrier testing, it is important to check to make sure that they've had sequencing in order to confirm the diagnosis. Even though this is a monogenic disorder, it truly is a tale of two genes. All humans have SMN1 and then a nearly identical copy of the SMN1 gene referred to as SMN2. These genes are nearly identical and both produce the SMN protein. However, there is a 1 base pair deletion between SMN1 and SMN2. Sorry, I did not mean to say deletion, a 1 base pair change between SMN1 and SMN2 that results in SMN2 splicing out more of exon 7 and therefore producing less of a functional protein. It is estimated that SMN2 accounts for about 10% of what SMN1 can do. So in individuals with SMA that are missing their SMN1 gene and therefore are not making any SMN1 protein, rely solely on their SMN2 gene to create the protein for their body. Individuals can actually have a large range of SMN2 genes. So anyone can have somewhere between 0 and the highest estimate that I've seen is 8 copies of SMN2. That's important when we think about this condition because the more copies of SMN2 you have, the more likely that you are making a higher level of protein. And if you are absent SMN1, the more copies of SMN2 could mean that you have a milder phenotype. When we think about SMN2 copy numbers, as I mentioned, there is a range. In one paper, they discussed individuals that had up to 6 copies of SMN2. As we'll start on the left side of the screen, individuals who have 1 copy of SMN2 and no copies of SMN1 are more likely to have a severe phenotype indicated by the darker pinker than 96%. However, a 4% can still have a milder phenotype and may not have the most severe form of SMA. When we get to 2 and 3 copies of SMN2, the story gets a little more blurry in that the distribution across different types of SMA is significantly spread out, making it very difficult to determine type of SMA solely based off SMN2 copy numbers. The picture becomes a little clearer as individuals have 4 or more SMN2 copy numbers, and that they are more likely to have a milder condition indicated by the very light pink on the bar graph. This is important because we know that there is a spectrum of SMA that historically has been classified into types 1, 2, and 3 in 1991 by a group led by MDA. However, since then, we've also added on a more severe type 0 and a more mild type 4. With each of these conditions, starting with type 0 being the more significant, their highest motor activity is what determines their type. So when we think about a classic type 1, they have a very early onset and would not achieve sitting. However, as we get into type 4, typically these individuals are still walking and may not be diagnosed until adulthood. I very briefly want to go through the types so that we have an understanding when we look at the trial data. SMA type 0 typically has a prenatal onset, and many of these children may not make it to a live birth. They tend to have hypotonia, contractures, may have fractures. They typically come out needing respiratory support, and the natural life expectancy is less than 6 months. And typically to get to 6 months, you need to have interventions for breathing and eating. SMA type 1 is the most common, accounting for about 60% of all 5Q-related SMA. The typical onset is between 0 and 6 months, and the hallmark features are significant hypotonia and muscle weakness. They may or may not have tongue fasciculations. As the children get older, you may notice a tremor in their fingers. Some can have contractures. It's important to note that kids with spinal muscular atrophy do not have any cognitive involvement, and so these are typically bright-eyed children who are interactive but have the inability to move. The natural life expectancy as of a couple of years ago was that 50% of individuals would be deceased by 7 months and 95% by 17 months unless they were on permanent respiratory support. When we think about the natural history, there were 2 different studies that looked at the natural history of type 1 SMA. Across the bottom, you can see that the milestones highlighted in gray are what we would typically expect from a child's development. And then the curves across the top are showing the survival rate for individuals with SMA. So one study showed that at 8 months, there was a 50% chance of death or permanent tracheostomy. Another study showed that there was a 75% survival rate at 8 months. However, by 20 months, there was only an 8% survival without permanent ventilation. So all in all, we would typically expect children with SMA type 1 to pass away before their 2nd birthday without meeting any motor milestones. SMA type 2 historically has a later onset between 6 and 18 months. Again, they may have hypotonia and weakness, absent or decreased reflexes, typical cognition. They may have had a slower development of a roll or crawl. They tend to be weak sitters, so they may tripod, but sitting independently is limited. And they could have a tremor. And although they may stand, they typically will not walk without assistance. However, the life expectancy is significantly different compared to type 1, in that they have 70% were still alive at 25 years of age. Type 3 and 4 I'm combining because they are very similar. Type 3 and 4 individuals achieve the ability to stand and walk without assistance. They may have progressive proximal weakness of the legs more than the arms, and their cognition is normal, and it typically does not impact life expectancy. There is a wide spectrum in when individuals with type 3 and 4 would be diagnosed, anywhere from childhood all the way up to adulthood, and there is suspicion that we are possibly missing many individuals with type 4 as they are never diagnosed. When we think about treating SMA, we divide it into 2 different categories. SMN independent, which means that we are not working on the gene itself, but we are working on other factors within the body that could influence how our muscles may move. One such one was looking at the skeletal muscles and how our muscle force frequency could be increased to make those muscles move more frequently and, in theory, strengthen those muscles. Today, I'm going to focus on the SMN dependent methods. So these are methods to treat SMA in which we actually directly address the genetic change itself. Now, as you may recall, we talked about two separate genes in relation to SMA. The causative gene, SMN1, which we could put forward with gene replacement or gene transfer therapy. And then we also talked about SMN2, which has been an excellent target for splicing modifications. So we, in fact, had two different avenues that we could look at to treat these children. In addition, because of the natural history of type 1 SMA being rapidly progressive, we had a study group in which a short amount of time could show us a difference between placebo and treated groups, making this a condition that was easy to do studies in. The first such drug that we're going to talk about is nusinersen or Spinraza. Nusinersen and Spinraza was studied in many different studies, and I've put their references on here so that you could look at them in more detail. But essentially, they looked at multiple different groups, including pre-symptomatic, infantile onset, and later onset spinal muscular atrophy. So they tried to cover types 1, 2, and some 3s with their study. In the first study, in which we looked at infantile onset SMA, they did a sham-controlled study, which means that individuals either received the drug or essentially received a poke that made it look like they had a lumbar puncture, which is how this drug was delivered. And what they found is that individuals that were in the treatment group had a higher probability of event-free survival. And event-free survival is defined as less than 16 hours of permanent ventilation. And in addition, they had a higher likelihood of overall survival throughout the trial. When we look at motor milestones over time, we'll first look at the sham-controlled study. So as you may notice, this line is significantly shorter than the other lines. This trial was prematurely stopped because there was a significant difference between the treated groups and the untreated group. So therefore, everyone was rolled onto treatment at an earlier date. When we look at the next group, this is individuals who were treated between under 6 months of age. And as you can see, over time, they developed motor milestones, which is different than the natural history of SMA when we would typically expect them to hit no motor milestones over time. But the most impressive group was the pre-symptomatic infantile onset SMA. And in this group, they looked at children who had either 2 copies highlighted in blue or 3 copies highlighted in green of SMN2. And these children were dosed before 6 weeks of age. You'll notice that the individuals had a significant difference between not only the sham control group, but also the individuals who were treated at an older age, indicating that while this drug works across the lifespan, it definitely shows significant improvement when we can give it before symptom onset. Due to this study, nusinersen was approved on December 23, 2016 as the first and only treatment for SMA in both pediatric and adult patients. The FDA approved this drug for all types of SMA and without age restrictions. This drug is injected intrathecally, and we do an initial loading dose over 60 days, and then it is a quarterly dose thereon for life. Many people always ask, what is the price tag for this drug? And the Spinraza list price in the US is $125,000 per injection. So therefore, typically $750,000 in the first year and $375,000 annually after that. Recently, at the World Muscle Society, they provided an update on that nurture trial. So again, this is the pre-symptomatic SMA patients that were enrolled before 6 weeks of life. All of the infants were greater than 25 months old and alive without permanent ventilation. If you recall, in the natural history study, only 8% of individuals were alive after 20 months of age without permanent ventilation. Additionally, 100% of the individuals in the trial had achieved sitting, and 88% had achieved walking alone. It is important to note that 12 out of the 15 with 2 copies of SMN2 were able to walk alone versus the 10 out of 10 for 3 copies of SMN2. Additionally, they were able to demonstrate that it still had a durability of effect, approaching almost 3 years of follow-up, and there was well tolerated with no new safety concerns other than those listed on the FDA label. We're fortunate in the SMA community that we have a second drug that has been researched as well, and this is gene therapy. And when we think about gene therapy, the goal of gene therapy is to deliver a fully functional SMN gene into the targeted motor neuron cells. We want that gene to then produce the sufficient levels of the protein, which is required to improve the motor neuron function. And we want it to have a rapid onset of effect in addition to sustaining the SMN protein. And so our first trial for gene transfer therapy was published in the New England Journal of Medicine in November of 2017, in which they looked at a cohort of 15 children. In those 15 children, the first cohort were dosed at a later age and with a lower dose compared to cohort 2. In cohort 2, you will see the CHOP INTEND is a measure that we have for very weak infants that we typically use on individuals with spinal muscular atrophy type 1. In natural history studies, no individual scored over a 40, which is indicated by the dashed line. As you can see in the second cohort that was dosed early and with a higher dose, all of the individuals, with the exception of one, surpassed that 40 mark and continued to make gains. You'll actually notice that some individuals reach the top of the curve, which is at 64 on the score, and therefore they look like they're holding steady, but it's actually because the measure does not allow for testing beyond a 64. In addition to the motor milestones, the individuals made other gains as well, and so I'm going to highlight across the bottom here. Again, we would typically expect that in a natural history study that children with SMA type 1 would not achieve any of these motor milestones or other achievements. And as you can see, 100% of the kids were able to bring their hands to their mouth, 92% could control their head, and as we move across, you will also see that 75% of the kids in the study were able to sit unassisted for greater than 30 seconds. If we're thinking about the natural history classification of SMA, that would indicate that these individuals were now a type 2 SMA. Additionally, 92% were able to speak, which is actually uncommon in SMA type 1. They were able to swallow, and about half did not require non-invasive ventilation, and about half did not require nutritional support. Again, this is drastically different from the natural history that we associate with SMA type 1. Additionally, the survival free from permanent ventilation, again, greater than 16 hours of ventilation, was achieved in all individuals. I've highlighted 20 months here with the red star. That is when we would have expected only 8% of individuals with SMA type 1 to be event-free, so meaning that they did not require permanent ventilation. And in this study, all individuals surpassed 20 months without requiring permanent ventilation in all 15 individuals. Because of this trial and ongoing trials, Zolgensma was approved in May of this year by the FDA for use in patients under the age of 2 with spinal muscular atrophy. This is different from our previous medication because it is a one-time intravenous infusion. However, there was a significant price tag associated with Zolgensma, and one dose is currently priced at $2.125 million in the United States. They also presented updated information at the World Muscle Society for their SPRINT study. Again, their SPRINT study is also in pre-symptomatic stage of SMA, so these are individuals treated under 6 weeks of age without any symptoms of SMA at screening. These children are reaching age-appropriate motor developmental milestones. No patient evaluated so far has lost their swallowing ability. None of the patients in the trial have required ventilatory support. And so far, the safety observations are similar to other studies of this drug. Ongoing studies are currently being completed for additional information from the clinical trial world about this. But what I really want to introduce you to is the true need for early diagnosis. We have some families that have graciously shared their kids with us so that we can show you what early treatment looks like. Both of these kids may look pretty typical, and it may not be that astounding to see the functioning that they are doing. However, our individual on the left has a sibling with type 2 SMA whose diagnosis was not made until she was 23 months, and she was not treated till 26 months. She is currently working on being able to crawl, and as you can see from her brother, he is up and walking. He is able to push his much older sister down the hall, and when he comes into clinic, we would not be able to tell that he has spinal muscular atrophy. The little boy on the right had a sibling that passed away from a very severe SMA type 1. As you may have noticed in the videos, he was able to sit, move, grab the rings and pull them back and straighten himself out. And he is currently working on cruising along furniture, things that we never would have expected to see for an individual with type 1 SMA. What makes these individuals significant is that because of their siblings, they had access to early testing and therefore access to early treatment. Both individuals were treated within the first month of life when they had limited or no symptoms of SMA. So how do we get to the road of earlier diagnosis? There's several different routes, and I'm going to spend a little bit of time talking about each one, about how we can aid families in getting this diagnosis earlier and leading them to treatments earlier. The first one I want to speak about is carrier screening. And so when we think about carrier frequencies, I mentioned earlier that across the board, the carrier rate is estimated to be around 1 in 54 individuals will be a carrier of SMA. However, as you will notice in this graph, some groups, such as Caucasian individuals, will have a higher frequency, whereas other groups, such as African Americans, may have a lower carrier frequency. However, carrier testing across the board may not identify all individuals because, as we talked about, the number of SMN1 and SMN2 copies varies by individual. So it is possible to have more than 2 copies of SMN1, sometimes with 2 being on one allele. Therefore, an individual may screen negative for carrier status, even though, in fact, they do carry a deletion. Carrier testing is limited by this, so a negative carrier test does not rule out being a carrier of SMA. Shortly after the approval of Spinraza, the American College of Obstetrics and Gynecology recommends that all individuals are offered carrier screening for spinal muscular atrophy as part of prenatal appointments. We all know that there are significant benefits of carrier screening. The first is that it allows for reproductive choice during pregnancy. It allows for more time for families to be educated about SMA and treatment options. It allows for earlier access to FDA-approved treatments if we know that a baby is at risk or has been confirmed to have SMA. And additionally, it allows for consideration of involvement in age-restricted research trials. As I mentioned earlier, 2 of those trials were for individuals that were diagnosed before 6 weeks of age. And so the only children who could truly be considered for a pre-symptomatic trial were those that had family members, so therefore had prenatal screening or screening at birth, or more recently, those individuals that were born in states that offer newborn screening and they were able to be picked up before they had symptoms. There are limitations to carrier screening as well. As I mentioned before, some carriers will be missed on carrier screening, either because they carry a point mutation and the screening test that was done only looked for deletions, which is the more common genetic change, Or they may be one of those 2+0 carriers, which means that you have 2 copies on one allele and 0 on the other. So your test report would report out that you had 2 copies of SMN1. Additionally, de novo mutations can occur. It's thought that there is about a 2% de novo mutation rate for SMA. One of the biggest limitations of carrier screening is that it shifts the diagnostic conversation from a pediatrician or a neuromuscular specialist to the OBGYN and to prenatal genetic counselors. Therefore, it's important that people in all different aspects of medicine are well versed in the different therapeutic options and the increasing need for earlier diagnosis of SMA. And when we do not have a family history, we do not have a phenotype when we do prenatal diagnosis, because as I mentioned before, and as I highlighted with that bar graph, the SMN2 copy number may provide us with some evidence as to whether or not we would be anticipating that the child would have a more mild or severe course, but it is not 100%. So therefore, we have to talk about the spectrum of SMA and not limit ourselves to one type of SMA. Where many of the states are starting to head is towards newborn screening. And so newborn screening typically relies on real-time PCR assay, which is specifically looking for the exon 7 deletion in SMN1. It can be multiplexed with skin, making it an easier add for states that are already screening for skin. And it's expected to identify at least 95% of SMA cases, again, looking for those homozygous deletions in exon 7. So individuals who have one deletion and a point mutation are expected to be missed on newborn screening in most states that are using the deletion method. It does have a high positive predictive value and a low false positive rate based on 2 studies that were done with the New York State doing a pilot study from January to December of 2016, in which they screened a little over 3,000 newborns, and in a pilot study in Taiwan, which lasted almost 2 years and screened over 120,000 newborns. So where are we in the United States regarding newborn screening for SMA? In July of 2017, Missouri was the leader with passing legislation adding SMA to their screening panel. It's important to note that they added legislation but did not start screening in July of 2017. Utah became the first state to implement permanent SMA newborn screening on January 29th of 2018. And later in that year, in July 3rd of 2018, it was approved by the recommended uniform screening panel that SMA be added to the newborn screen, and it was signed by Secretary Azar. I apologize, my computer is frozen, but we'll get there. There we go. So currently, based on information that was pulled off New Step's website on 11/2/2019, the states that are in blue are those states that are currently performing universal screening for spinal muscular atrophy. If we look at the newborn screening program map that is provided by Cure SMA, you'll see a slight difference because they include the states that are performing universal screening. They are also including those individuals that have adopted a plan but have not yet implemented it. They are in the lighter shade of purple. And then those that have the stripes are states that are currently performing a pilot for SMA. So as with any newborn screen, there are some limitations. The biggest one is that it is not universal and that it requires state-by-state approval. So some states have been able to rapidly add SMA to the newborn screens, while other states are still struggling to add it. This is important to know if you take care of children that may have had newborn screens in another state. It's always crucial to actually see that newborn screening result to see what conditions were screened for. Additionally, children who were born outside of the U.S. are not always have access to newborn screening, and SMA has not been widely picked up on newborn screening in foreign countries. Additionally, point mutations, which account for about 5% of all patients with SMA, cannot be detected, and so those individuals are going to be missed on newborn screening. The biggest struggle with newborn screening, as with carrier screening, is that there is no phenotype at the time of the diagnosis in most cases, which means that the spectrum of SMA may need to be discussed with families, and that can lead to a lot of uncertainty when you're discussing different therapeutic interventions. For all individuals, a clinical diagnosis is needed to support the findings of both carrier screening, prenatal diagnosis, and newborn screening. And so we think about doing additional testing. So we recommend that confirmation testing, which includes SMN2 copy numbers, should be performed on all individuals who screen positive on the newborn screen or who have symptoms of SMA. We also believe that there should be a consideration for antibody testing for AAV9, which is required in order to move forward with gene therapy. Having this information allows for you to have a comprehensive discussion with families regarding treatments that are currently available. And then patients who present to clinic with symptoms of SMA should have comprehensive SMA testing, which includes deletion and sequencing, even with a negative newborn screen. It's always important to remember that the newborn screen is just that. It is a screen. It is not a diagnostic test, and it does not rule out all cases of SMA. And then I would like to thank all the families who allowed us to share their children's stories. And just end with the fact that early detection includes earlier access to options. And those options, as we've just discussed today, are to continue with standard of care. It is to have access to FDA-approved therapies and to have access to clinical trials in which pre-symptomatic is one of the requirements for those trials. In addition to the FDA-approved therapies that we have discussed today, there are several different clinical trials that are currently ongoing for individuals with SMA. And so our options for these families is going to be drastically different, even possibly in another year with a third FDA-approved therapy. Thank you so much for your time. We did leave quite a bit of time for questions, so please submit those through the system as indicated in the instructions.
Thus far, we have not received any questions or comments via group chat. I am unmuting microphones right now for everyone who is or who has joined. So if you do have questions, please feel free to speak up. We got one that came in. All right, we have a couple that have come in so far. Christy Healy. She wants to know, what is the status for Colorado for newborn screening for SMA?
So we are really excited because it is going to be voted by the Board of Health on November 20th as to whether to include or not include SMA on the newborn screen at this time. If it is approved, then the predicted go-live date for screening for SMA on the newborn screen will be January 1st of 2020.
Did that answer your question, Christy?
Yes, thank you very much.
You're very welcome. It looks like we did have another question come in from Dr. Mokrahysky. Does the state need to have comprehensive treatment in place before starting screening?
I do not believe that your individual state has to have the treatments available. I think that one example is that many patients within the Rocky Mountain region come to our clinic. So we take care of kids from Wyoming and Western Kansas and Nebraska, sometimes the Dakotas, and Texas and New Mexico. So all of those states have a treatment center. It may not be located in their states, but it is within traveling distance for those families. So I think that starting screening and identifying those patients and then knowing where your closest neuromuscular clinic is sufficient for being able to identify those children early and having a treatment plan in place.
Thank you, Dr. Mokrahysky. Did you have any other questions or comments?
Not right this minute, no.
Thank you. Vera, did you have any questions for us?
No, I don't think so. Thank you very much.
All righty. I am just one by one unmuting each microphone. So if you've got something for us, we would definitely like to hear your comments or questions. Gwen, do you have anything for us today?
No, I don't, but thank you so much.
Thank you.
While we're going through questions, I'm going to reverse my presentation to the videos because I always think those are fabulous to watch while we're going
We do
through
have one
things.
more that has come in. Does the state need to have comprehensive treatment in place before starting screening?
That
And what are some safety considerations to consider for the gene therapy?
So the gene therapy did come with some warnings with the FDA approval. So we have seen that there has been an immune response. And so individuals who are being treated with gene therapy are also placed on steroids because there is a risk of acute serious liver injury. So therefore, we monitor liver enzymes very closely. And individuals who have increased liver enzymes are kept on steroid doses for a longer time before they are tapered. But that is one of the significant risks that has been seen with gene therapy, is that individuals may have a response that could cause serious liver injury.
Melissa, this is Erica. Quick question for you as you're showing us your wonderful videos. The kiddo on the left, if I recall, was a kiddo that received Spinraza.
Oh, yes.
And the kiddo on the right, was that a Spinraza kiddo or was that a
Thank you.
gene transfer kiddo?
That is a very good question. I apologize. The child on the left is receiving Spinraza, and the child on the right has received Spinraza and gene therapy. So they have actually received both treatments.
Okay. If we don't have any other questions, if you had some additional information you would like to share, otherwise, we will wrap up a little early.